Good afternoon, everyone. Thanks for attending the last session. Okay, so I'm actually going to have a slightly narrower focus on my presentation than what's been stated. So I'm going to be talking specifically about operational research to inform better malaria elimination programs. And I think this is a key element of health system strengthening. It's working out how to make best use of public health data to ensure that interventions are delivered effectively as possible. One of the methods that I'm going to focus on is spatial decision support systems. So these are computerized systems that are designed for supporting decisions where there's a geographical component to that decision. And they're typically based around geographical information systems. So these are computerized databases which are similar to other types of databases, with the key feature being that information is geolocated and information can be linked according to location. And these systems, they're based on a geographical information system platform, but they have additional functionality, so including things like analytical models, geographical or graphical map displays, tabular reporting capabilities, and expert knowledge of decision makers incorporated as decision support modules. There are many different types of spatial decision support systems. They range from national level or even global level systems that might present static maps that might be updated irregularly, right down to local systems that operate in real time and are dynamic. And it's the latter type of system that I've been focusing on in recent years with my research. So the analytical component, or the analytical aspects of these decision support systems, tend to be fairly simple. Usually they involve the generation of summary statistics, basic maps for visualization, etc. They don't tend to involve or require complex analytical functionality. However, the systems that they're embedded within are complicated, so including the human resources, the telecommunications, the national infrastructure, and all of the other types of information management systems that exist. So trying to integrate a system like this into that bigger framework is where the complexity lies. I'm going to illustrate the application of spatial decision support systems in two different settings. One is Solomon Islands and Vanuatu, which, as Stephen mentioned, is one of the countries where malaria incidence has not been going down as rapidly as in other parts of the region. And the other example is going to be Bhutan, where we have seen significant reductions in malaria burden and nearing elimination. So before I get into the spatial decision support system, I've got a slide here showing a risk map. So a risk map is it's a spatial prediction map, and it's generated using data from a sample of locations, and that data is then used, or those data are then used to generate a model which incorporates information on the environment and also incorporates information on the spatial correlation structure of the data. That information is put together in order to estimate the prevalence or incidence of a disease, in this case malaria, in non-sampled locations. So these maps are very useful in static applications. So here we've got an example of a map that's used at the baseline stage of a malaria control program in Vanuatu, but they don't tend to be easily updatable and they don't tend to be very dynamic. This is the kind of mapping approach that's used by the Malaria Atlas project to produce global estimates of malaria disease burden, but here we've got a very local example. So spatial decision support systems are a very different sort of thing. So that map I showed you involved very complex analytical approaches, Bayesian model-based geostatistics, but the spatial decision support systems don't require any of that, and they're much more accessible to local users. So the spatial decision support systems that we've developed have three major components. One is geographical reconnaissance, and this involves rapidly mapping and enumerating all households in elimination zones using global positioning systems, and creating or generating a database that has the household locations of everyone in that zone. And then this provides a high resolution geospatial data set which can then support malaria decision making. Now, this sort of approach may not always be feasible, particularly in large countries with very large populations, and you need to, rather than having a a total enumeration at the outset. You might need to do a gradual building up of a database of the population in elimination areas. And this map here just shows a screenshot of the decision support system showing the locations of all the households. The second module of the spatial decision support system is for managing the scaling up of interventions, in particular for the planning of the activities of intervention teams, whether they be people going out to deliver bed nets or going out to do indoor residual spraying. And then tools that are available during the actual implementation. So these will be maps of households that a particular spray team or a particular bed net distribution team, there's a list of households that those people will then visit during their day. And here we have some photographs of an operative in Solomon Islands who's reading off a map that's been produced by the Spatial Decision Support System, working out the households that he needs to visit to spray with insecticide for that particular day. And then the third module of the Spatial Decision Support System is around supporting surveillance response. So this involves mapping of malaria cases in real time. So as you recall, we've got a geographical database of all of the households. So when a person comes to a health post with malaria, that information then gets transmitted to a central location. It's known where that person lives, and then that's mapped in the Spatial Decision Support System. And then there's functionality in the Spatial Decision Support System to generate buffers around new cases. And then lists can then be generated of households that reside within that buffer for the purposes of going out and doing things like reactive case detection, fever screening, and delivery of antimalarial drugs. So we did a little bit of evaluation of the Spatial Decision Support System in Solomon Islands and Vanuatu. This was qualitative evaluation where we did in-depth interviews and focus groups involving all malaria personnel in the countries that actually utilised the system. And we found very positive feedback with regards to the system from the operatives, including that it provided efficient and accurate information, that it assisted with all facets of intervention management, including planning, implementation, monitoring and evaluation, and helped identify transmission foci and support targeted responses. And also that it was highly acceptable to local users. So this all sounds very positive, but in reality, this was a small-scale qualitative evaluation of a system, and we really need larger-scale, more rigorous validation studies in order to really know that this actually makes a difference in terms of the management of malaria elimination programs. So before I move on to the second example, which is Bhutan, I'm going to briefly touch on border malaria, which Stephen mentioned is a key issue with the elimination of malaria. In many countries in the Asia-Pacific region, the burden of malaria is highest in the border regions. Here we've got maps of Yunnan province in China. It's relatively old data now, but it shows that the incidence of malaria is highest on the borders, on the border between Yunnan province and Myanmar and Laos. We've also got a map of Vietnam showing that incidence of malaria is highest all down the border with Laos and Cambodia, and a map on the right of Bangladesh showing that by far and away the highest incidence in Bangladesh is on the border with the Northeast Indian states and Myanmar. So why is that? Well, it's because border areas are porous and people can move from high burden countries to low burden countries in an unregulated way. Populations in border areas are often marginalised. These tend to be areas where the government has little authority, and often where there are geopolitical issues. Also where there's the terrain is conducive to the transmission of malaria and non-conducive to the delivery of interventions. And these areas tend to be far from centres of administration and investment, including in health, delivery of healthcare. And also often there's a lack of alignment between intervention strategies between countries on either side of the border, which impacts on efficiency of interventions. So I mention that because the next study that I'm going to talk about is Bhutan, where pretty much the entire burden of malaria is very closely linked to the border with India. So there's very little now in local or indigenous transmission of malaria. Most of the malaria in Bhutan is imported from across the border from Assam and West Bengal state. And this creates significant operational challenges for malaria elimination aspirations in that country. So we did some operational research in Bhutan to sort of understand the challenges that the malaria elimination program in Bhutan faced, and wanted to collect some data and also to develop a spatial decision support system for that country. So we did a survey in 4 sub-districts along the border with India, and we found, of the local population, and we found a 0 prevalence of malaria using RDTs, rapid diagnostic tests, which confirms very low transmission in that area. We also did a survey of bednet ownership and use, and we found very, very high coverage of bednets. 99% of people had a bednet. 94% of people regularly slept under their bednet. And in a very small number of people who weren't regularly sleeping under their bednet, they slept under the bednet for most of the year, but didn't tend to sleep under it during winter. But this is a very small number of people, which suggests that coverage is very high and use is very high. And if there is any concern, it would be in the malaria, the low season for malaria. Furthermore, we asked whether people slept under a bednet the night before, and almost 99% did. We also asked about bednet maintenance, washing, and what they did if the bednet was damaged. About 2/3 actually followed guidelines, washed their bednet every 6 months, but around 1/3 washed their bednet less frequently than advised. So this might have an impact on the efficacy of the bednet. And we also asked what people did if their bednet was damaged, and the vast majority of people repaired their bednets if they were damaged. And most people followed guidelines and kept the bednet hanging in their sleeping place rather than packing it away, which is associated with higher use. So generally speaking, it seems that things are looking good in Bhutan. So there's very high coverage, very high use, most people following guidelines, and no evidence of local transmission from our survey, but and certainly which is indicative that there is low transmission in that area. So that's all looking good. In terms of sustainability, though, it's important to look at funding sources, and in terms of sustainability, it's important for countries as they approach elimination and go beyond elimination that they really take ownership and that there are local government funds made available. Over the last half decade, the Royal Government of Bhutan has funded around 28 to 30% of the costs of malaria elimination. Most of the fundings come from the Global Fund, to fight AIDS, tuberculosis, and malaria, and this fluctuates annually because of the different rounds of global health funding and of Global Fund funding and the intermittent delivery of interventions like bed nets. But also the government of India is a major contributor, providing almost as much funding as the government of Bhutan for their malaria elimination activities, which suggests that that there might be some issues around sustainability, particularly if Global Fund funding stops, for example. And that would be an issue moving forward. And then, as I mentioned, another thing that we did in Bhutan was to develop a spatial decision support system modelled on the one that we used in Solomon Islands and Vanuatu, and we also aimed to do a little bit more of a thorough evaluation. So in Bhutan, we actually compared sub-districts that used the spatial decision support system for the delivery of bed nets to sub-districts that didn't. We found no difference, so that suggests that the spatial decision support system didn't improve the coverage of bed nets. Perhaps not surprising given that the local control program without the aid of a decision support system had already achieved extremely high coverage. But we believe that the spatial decision support system was particularly useful for their surveillance response because they didn't really have an objective framework for managing things like reactive case detection in the country prior to the development of the spatial decision support system. So if there was a case of malaria in Bhutan, there would be a prospective enumeration of households around that case, and in order to deliver reactive case detection and other interventions, whereas with our geographical reconnaissance and and prior enumeration, they were able to extract that information directly from the database, generate buffers, and ensure that they got good coverage within the buffer zones for their reactive case detection. So we think that this might have been the major advantage of the spatial decision support system within the context of Bhutan. So to conclude, significant progress has been made towards malaria elimination, as Stephen mentioned. Key challenges remain, and Stephen's also mentioned most of these: vivax malaria, anti-malarial drug resistance, border malaria, and particularly the risk there being importation of new cases into receptive areas and the resurgence of malaria, mobile and migrant populations, inadequate health systems, and importantly, from the research that I've been doing, low capacity to utilise public health data. So in terms of the way forward, I'm running over time. We need to ensure continual investment even when malaria reaches a very low incidence. We need to invest in cross-border regional and global cooperation, so APMEN and APLMA are good examples of that. We need to build stronger health systems, improve capacity to utilise public health data, and this is where spatial decision support systems and other decision support systems come into bear. And we need more operational and implementation research in order to design and upscale the interventions that we already are delivering, but in a more effective and efficacious way. And that's all I've got to say. I'd like to acknowledge two of my former PhD students, Kinley Wangdi, who did the work in Bhutan, Gerard Kelly, who did the work in Solomon Islands and Vanuatu, and various other collaborators from the WHO and the countries involved. Thank you.